I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. Yeah, I think there are evolving treatment strategies specifically for malignant mesothelioma that's unresectable or not going to be going on to surgery. We know that we tend to classify these mesotheliomas as epithelioid and sarcomatoid. We think that epithelioid is a little better actor and a little better prognosis than sarcomatoid. And I guess to answer the question about what to do in second line and beyond, it may be important just to briefly talk about first line options, because when we talk about first line options, that really allows us to delve into what we do next. And what we know is that in the past 10 years, some of the chemotherapy strategies have evolved. We know one of the cornerstones of treatment for unresectable malignant mesothelioma, plural malignant mesothelioma, is platinum pemetrexed. So there's been several pieces of data to suggest that either cisplatin with pemetrexed or carboplatin with pemetrexed is a reasonable first-line strategy. Adding on to that, the question is, can you graft on bevacizumab to platinum pemetrexed? And I think that there's been one data set that's shown a survival advantage with that. But more recently, we've had a direct comparison of dual checkpoint blockade to platinum pemetrexed. And in that study, the trial was randomizing patients to nivolumab, ipilimumab versus one of the standards, platinum pemetrexed. And that trial did show a survival advantage that was restricted, that was in the intention to treat analysis, but seemed to be more pronounced in the epithelioid subtype. Now, I mentioned first line strategies because that really sets the stage for second line. So if we're going to start with nivolumab and ipilimumab for patients with mesothelioma, I think a very reasonable second-line strategy would be platinum pemetrexed. And the question would become, first line or second line, do you continue pemetrexed or not? One could also consider platinum pemetrexed with bevacizumab. Now, again, this is an extrapolation. This is data we've used in the front line. But if we are going to start with one of the new standards, nivolumab, ipilimumab, I would consider platinum pemetrexed as a second line with continuation of pemetrexed or platinum pemetrexed bevacizumab. I think if you're starting with chemotherapy with platinum pemetrexed first, one could make the argument, again, extrapolating, to use dual checkpoint blockade second line. There's not a lot of great data as to what to do in these refractory settings. And I think we are trying to alter the sequence from first line data. So if we're using one first line strategy, maybe using second line, the one that we didn't choose, and vice versa. This is a call for clinical trials. I think that we are desperate for novel therapies for the refractory setting. What to do after potentially dual checkpoint blockade and then chemotherapy with platinum pemetrexed is a real challenge. There's data with single agent single agent gemcitabine, single agent paclitaxel, but this is a call for clinical trial. So I would say that any patient who is a mesothelioma patient should be referred to potential clinical trials after first line therapy options and potentially second line are exhausted.